Good afternoon, everyone, or good morning, depending on where you are across the country. My name is Dr. Astro Webb, and I am the Director for the National Center for Health and Public Housing. I would like to take the opportunity to welcome you to today's webinar entitled Resources with Special Population Point of Contact Personnel. Our webinar today, we will have for our learning objectives, we are going to provide an introductory and informative webinar for you highlighting the special populations and the corresponding organizations. North American Management will be presenting on the public housing health centers. The Farmworker Justice Organization will be representing the Migrant health centers, and this is in collaboration with Farmworker Health Network, Health Outreach Partners, Migrant Clinicians Network, Migrant Health Promotion, the National Association of Community Health Centers, and National Center for Farmworker Health. And then we will have Healthcare for the Homeless Council representing the Homeless Health Center program. Upon meeting our goals for today, you as participants should be able to identify which groups are considered to be special populations. You will also be able to describe the challenges that safety net providers face when serving special populations, and you should be able to list methods of outreach when serving these special populations. As many of you know, HRSA and the Bureau of Primary Health Care funds organizations like the National Cooperative Agreements to provide training and technical assistance to community, migrant, homeless, and public housing-based health centers. And in collaboration with you as primary care associations, we want to help develop opportunities for health centers who would like to serve special populations. Most of our organizations and HRSA grantees have much experience and knowledge, as well as resources available to share with you in meeting the needs of your special population. Although there are many special populations, on today's presentation we will focus on those special populations covered under Section 330 of the Public Housing Service Act. So although, as I mentioned, there are many special populations, we will focus on those special populations that are defined under Section 330 of the Public Health Services Act, authorizing legislation of the health center program. And that is namely the Migrant 330G program, the Homeless, which is the 330H program, and the Public Housing, which is the 330I program. Each of the special populations will be addressed by one of the national corporate agreements that provide training and technical assistance to the community health centers. In today's presentation, of course, the entire presentation will be recorded, and we will be able to share an audio file as well as the PowerPoints themselves, which will be available within the next 24 hours. We are going to ask everyone to please hold all questions until the end of the three presentations, at which time we will address all questions. So first you will hear from Ms. Alexis Bill, who is representing Farmworker Justice, and she will be speaking on all of the migrant population. She will be followed by John Lazier, the Executive Director for Healthcare for the Homeless Council, and then I will follow with the presentation on public housing. So Ms. Guild, thank you so much for joining us today, and I will now turn it over to you. Thank you.
Thank you so much, Dr. Webb, and thank you everyone for joining us today on this webinar. My name is Alexis Guild. I am with Farmworker Justice, and I will be talking about migrant and seasonal farm workers. So quickly, let's talk about demographics of farm workers in the U.S. There are an estimated 2 million farm workers in the U.S. Estimates do vary, but generally 2 million farm workers is the agreed upon estimate. About 4 million if you include families. 500,000 children estimated do actually work in agriculture because it is legal for children as young as 12 to legally work in the field. Now, you will see on this slide, we have a map of the U.S., and you will notice that, every single state does have farm workers. The highest migrant impact state, should be no surprise, is California. And then actually, it's followed by Florida, and then Oregon, Texas, Michigan, North Carolina, Georgia, New York, Illinois, and South Carolina. An estimated 78% of farm workers are male, and an estimated 78% of farm workers are also Hispanic. 71% of farm workers are foreign-born, primarily from Mexico, about 68%, although about 3% are from Central America, specifically Guatemala, Honduras, and El Salvador. And that percentage is actually increasing due to various events going on in the countries and migrants coming across from different countries to the U.S. Spanish, not surprisingly, is the dominant language. About 71% of farm workers speak Spanish as their primary language. However, and I'll discuss this in a moment, there is an increasing number of indigenous farm workers from southern Mexico and Guatemala who speak an indigenous language as their primary language and Spanish as a second language. 78% of farm workers do earn below $20,800 a year. And in fact, the median personal income for a farm worker is between $15,000 and $17,499 a year. 41% had no health care visit in the last 2 years. This may partially be due to the fact that 64% of farm workers do not have health insurance. And this is something to keep in mind as we think about the Affordable Care Act and enrollment that will occur beginning in October. And of those that do have health insurance, the majority do get it from their employer. So how have things been changing in the farm worker communities in the U.S.? There are an increasing number of foreign agricultural workers who are on short-term visas, and they are called H-2A, agricultural guest workers. Now, currently, they do comprise between 3 and 5% of the U.S. farm worker population, although that is changing. I recently heard that in the Coachella Valley, in California, that there is a growing number of H-2A guest workers who are harvesting tomatoes. So it's an increasing number, and who knows what will happen in the coming years, but something to keep in mind. There are more males who are traveling alone. There is, as I just mentioned, increased migration from indigenous communities. Now, these are primarily from southern Mexico. The largest community, and actually the largest growing and the fastest growing farm worker population in the U.S. is from the Mexican state of Oaxaca. They speak languages such as Triqui, Mixteco, and other languages. An estimated 4% of farm workers in the U.S. speak an indigenous language as their primary language. So again, when you think about doing outreach to farm workers, it's important to think about the language and cultural barriers, which I'll discuss a little bit later on, and to think about the barriers for indigenous languages and indigenous farm workers who may have different cultural beliefs and different languages than the other Spanish-speaking farm workers who you may encounter. Interestingly, there are more farm workers who are doing seasonal work as opposed to migratory work. So a lot of farm workers, traditionally there have been these migrant streams along the East Coast, the Midwest, and the West. In the East Coast, they would travel from Florida up to New York and Maine. In the Midwest, they would travel from Texas to the Michigan upper Midwest area. And in the West, they would travel from California up to Washington State. And those streams have changed. They've changed in terms of farm workers not strictly keeping to the streams, but going from California to Arizona or going from Florida to Michigan. So that has changed. But what's also changed is that a lot of farm workers are actually settling in their communities. So instead of migrating, they're becoming seasonal farm workers, working in agriculture during the harvest, and then engaging in other industries such as construction and meat processing and dairy and so forth during the off-season. There's also less circular migration between the U.S. And Mexico border, and that could be due to increased security and the dangers of crossing across the border. Now, agriculture is one of the most hazardous occupations in the United States, and you'll see why in a moment. But in 2010, there were an estimated 323 farm workers who died of work-related injuries, and that's a huge number. But only about 20%, if you use HRSA UDS data, only about 20% of farm workers and their families visited a community or migrant health center in 2011. So even though it's a highly dangerous job, there's not a high rate of healthcare utilization amongst the farm worker communities. In terms of work-related health risks, agriculture is extremely dangerous for many reasons. Heat stress, by being outside, not having access to water, not having access to shade, musculoskeletal injuries as a result of stooping and harvesting of crops, falls from ladders when harvesting tree crops such as apples and dates, and lacerations from tools. But pesticides are something to really keep in mind when you think about farm worker communities as well, because pesticides not only affect those who come into contact with pesticides, including applicators and farm workers who harvest fields recently sprayed with pesticides, but also a lot of pesticides can be taken home either through drift or through the groundwater. There's a huge number of take-home and exposures to pesticides by farm workers who are not working in the field but live or work adjacent to a field that has been recently sprayed. And according to the EPA, there are an estimated 10,000 to 20,000 incidents of pesticide poisonings every year. And that seems high, but actually it's widely recognized that pesticide incidents are actually underreported, and this is due to basically for two main reasons. One being that farm workers may not seek medical care for mild symptoms, but the other being that there is sometimes a misdiagnosis on the part of the provider, because often pesticide-related illnesses mask themselves in other common illnesses, and therefore misdiagnosis is a huge issue. Real quickly, other illnesses, other risks for farm workers, unsanitary conditions both in the fields and in the homes. I want to point out that, farm worker housing can range from apartments to trailers to cars to tents at the edge of the field, and that's one photo that you see in that slide. That's in San Diego, in the canyons in North San Diego County. And because of these conditions, farm workers may lack access to clean drinking water and sanitary facilities. There's also a huge issue of overcrowding. One Oregon study found that indigenous farm workers averaged between or around 6.4 people per household, and that Latino farm workers, so non-indigenous Latino farm workers, averaged about 4.6 people per household. So overcrowding and lack of access to sanitary facilities exacerbates these diseases related to unsanitary conditions. Mental health, huge issue, due to isolation and due to immigration status or due to discrimination. There are a lot of reasons why mental health is a huge issue. In one 2008 North Carolina study, they found that 40% of the farm worker participants in this study reached the threshold for potential clinically significant depression. So mental health, behavioral health, substance abuse, domestic violence, definitely something to think about, again, when you are doing outreach and working with farm worker populations. Chronic conditions like any other population, diabetes, hypertension, HIV/AIDS. Interestingly, I was actually just in the Coachella Valley in California, and I was told that there are increasing rates of asthma in the farm worker population, maybe due to pesticides or other reasons, who knows, but there are an increasing rate of asthma diagnoses taking place in the Coachella Valley. According to HRSA's 2010 Migrant Health Center report, 59,756 patients were given a primary diagnosis of hypertension, and 53,000 patients were given a primary diagnosis of diabetes. So what are the barriers to care and healthy living for these farm worker communities, for farm worker families? Cultural issues. So being from, especially the foreign-born farm workers, especially the indigenous farm workers, thinking about their own beliefs. For example, in indigenous communities, there is a belief of mal de ojo, of evil eye, of hot and cold, and how these cultural beliefs influence their opinions on medical care and seeking medical care, and how they're perceived by health centers and outreach workers and others. Isolation, they're rural, lack of transportation. Lack of transportation can certainly impact someone's ability to get to a health center and access medical care. Surprisingly and interestingly, ironically, farm workers, the ones who harvest our fruits and vegetables that we eat every day to keep healthy, are extremely food insecure, and they lack access to healthy foods. It's ironic, but it's true. And part of that is due to poverty. As I mentioned, they have a low income level, and they live in substandard housing along the fields in rural areas. There's also, specifically for farm workers, there's limited job security and a lack of sick leave. Now, when a farm worker, most farm workers work on a piece rate, which means that the amount that they are paid is based on how much of a crop that they pick. So they don't get sick days. So when a farm worker gets sick, he or she has to make a decision of, will I leave my job and lose those wages for the day and spend the money to go to a health center, or do I just be sick and deal with it and make money for my family? And that's a difficult decision to make for anyone. It would be a difficult decision to make. And of course, immigration status. It's estimated that around 50% of farm workers lack legal status, and discrimination with everything that's been going on, being Latino, being indigenous, discrimination is a huge issue. So the challenges for health centers include continuity of care and creating a patient-centered medical home for migrant populations. This is partially due to the fact that farm workers migrate, so it's difficult to continue care from one health center from one state to the next. Linguistic and cultural barriers, which I discussed. Outreach and engagement. A lot of health centers have a difficult time identifying the farm workers in their areas and engaging them. And so that is something that can be really challenging for health centers who work with farm worker populations. And of course, health insurance. Because farm workers don't have health insurance, the vast majority, because, and many of them don't really get connected to workers' compensation. Not all states cover farm workers for workers' compensation. It's not a requirement in all states. So farm workers aren't used to utilizing health care. You see the low utilization rates, and that's something to keep in mind when implementation of the Affordable Care Act and enrollment begins, because connecting farm workers to health insurance will be a real challenge. So we are the Farmworker Health Network, and we are a organization. We are six organizations that provide training and technical assistance to migrant and community health centers on various issues related to migrant seasonal farm workers. So this page has our website. We are Farmworker Justice, that's my organization, Health Outreach Partners, Migrant Clinicians Network, Migrant Health Promotion, the National Association of Community Health Centers, and the National Center for Farmworker Health. And we have a resource guide that the Farmworker Health Network put together, which highlights the different resources that we can provide to health centers. So if you're interested in receiving that or in finding out more about the training and technical assistance that the Farmworker Health Network can provide to you, please feel free to contact me. My information is at the end of the presentation. Thank you so much.
Hello, I'm John Lozier. I'm the Executive Director of the National Healthcare for the Homeless Council. And I'm here to say hello from Nashville and to welcome you again to this presentation. I'm going to be talking about supports for health centers who are serving people without homes. I'll make a fairly brief presentation here. Much of the homeless population looks a lot like the farm worker population that you've just heard about. It's a major portion of the health center population. Homeless people are perhaps a surprisingly large segment of the health center population. Healthcare for the Homeless programs are funded at 8.7% of the health center budget. Overall, we see about 1 million homeless users across all health centers, and the HCH specifically funded programs see 4/5 of those, about 825,000 HCH clients nationally. Or homeless, HCH clients in those projects. You see here something of their demographics. None of this is very surprising. The uninsurance numbers look a lot like the numbers for migrants, and the Affordable Care Act will have some impact there. The homeless population is generally pretty stable in this country since the outbreak of homelessness in the early 1980s. This slide reflects the single night counts that are done in January every year by the HUD-funded programs. They count just over 600,000 homeless people each year. Those numbers are down just a little bit overall from the previous year, but in 28 states and the District of Columbia, they're increased. Homeless people are all sorts of folks. It's not just the chronic street people whom one might imagine, and it's not just the veterans whom we know about, but a lot of people and families. The overall trends are reveal that while numbers overall have gone down just a little bit, that's been affected by larger families showing up in homelessness. And of course, the other more traditional populations are still there. The trends are that more and more homeless people are served each year at health centers. People are, in this economy, doubling up more than previously, we think, though that's a hard population to count. And we're certainly seeing more mental health problems. We are actually seeing less substance abuse issues in our work and less use of shelters. That's been on account of a shift away from shelters and the federal funding that's coming from HUD to deal with homelessness and more toward permanent supportive housing. There are 248 healthcare for the homeless grantees across the country. This is where they are the colors of our dots and push pins don't mean anything other than we don't know quite how to control this map yet. Generally, in terms of the health of homeless people, their health situation is dismal. In all categories of health problems, illnesses, and injuries, homeless people are 3 to 6 times, experience those problems at 3 to 6 times the rates that other people do, and their mortality is horrible mortalities. The result, homeless people tend to die around age 50, as opposed to a life expectancy for the rest of the country at about age 80. They have multiple complex comorbidities, chronic diseases, acute conditions, much of it relating to the conditions in which they live. You saw a great picture of that in the Farmworker slide. We believe that in serving about 1 million homeless people in the health center program nationally, we're serving maybe a third to who knows what, a quarter, a fifth of the overall homeless population. Baseline numbers are very hard to come by. From UDS reports, here are the things that we see most frequently in a clinical sense. Hypertension, like probably every primary care practice, hypertension and upper respiratory diseases are prominent. Smoking's a huge factor in that for homeless people. Nutrition that they can't control, alcohol, and just the stress of being homeless certainly contribute to that condition. As with farm workers, and as one might imagine, depression and mood disorders are very prominent among homeless people. Diagnosis and treatment is difficult. It's complicated by comorbidity with substance abuse disorders, which we'll touch on in a minute. Medication management is a very difficult problem for people who are living on the streets and lose their medication or have it stolen, and the behavioral health system is really not sufficient to respond to the needs of our homeless clientele with mental illnesses. We'll add that in addition to the huge burden of depression and mood disorders, the major psychiatric disorders are also a huge factor in homelessness, schizophrenia in particular. Diabetes, again, like a lot of primary care practices, is a major problem for us and our clientele. Medication, a problem for homeless people that most folks can get their minds around is where do you refrigerate your insulin. We publish adapted clinical guidelines that attempt to direct physicians to other alternatives than medications that need to be refrigerated. But the theft of medication and of syringes is a particularly significant issue. Nutrition, again, if you're relying on shelters and dumpsters and handouts and fast food joints for your nutrition, you're not going to be able to control it and maintain an appropriate diabetic diet. We try to teach people self-management skills. We engage in self-management goal setting and train clinicians in how to do that. Circulatory and foot issues for diabetics are particularly pronounced for our population simply because people have no place to rest, to put their feet up. They're moved along by the police and the business improvement districts and everybody else during the day. Sometimes sleep sitting up on benches, fluids pool in their feet and legs and cause horrible edemas and other problems. And vision and oral health care are difficult to obtain for our uninsured clientele, and of course closely related to diabetes. I separated in these slides conditions from health issues and just want to highlight a couple. Addictions are very, very prominent in the homeless population. They drive people to the streets in the first place because they lose their support wherever they are doubled or tripled up. And then people often start drinking once or using other drugs once they are on the streets. Addictions treatment services are a required service in healthcare for the homeless. That's not the case for other health center grantees. It's a reminder that healthcare for the homeless is far more than traditional primary care enabling services, and these addiction services are very central to the model. They're important. We know from a recent study in Boston that the leading cause of death there, and we think in other cities as well, for homeless people currently is overdoses of opiates. It's generally not street drugs like heroin, but prescribed opiates that have made their way into the underground economy, if you will. But that's what's killing homeless people, in addition to the cancers and heart disease that we've known about as so important in our population for a long time. One effective treatment for opiate addiction is buprenorphine. There are issues currently being addressed by HRSA that have to do with when a practice adopts buprenorphine treatment by having one or more of its providers certified to prescribe buprenorphine. Does that affect scope of project? It's an issue we hope to see resolution of soon. Chronic pain drives a lot of homelessness, a lot of the substance abuse, and we have a number of resources on addictions treatment and homelessness, including an online course on the neurobiology of addiction that might be of interest to providers that you deal with. Health issue number 2 is uninsurance, huge for us, 69% of HCH clients uninsured. That's important both for health center bottom lines and for homeless people's access to care, and particularly not so much for primary care as for specialty care and hospitalization, because their conditions are so complex. The 2, 3, 4 diagnoses of chronic diseases, the need for specialty care is huge. Health centers, of course, are required to provide benefits and assistance and have been funded recently by HRSA to engage in outreach and enrollment around the Affordable Care Act, and particularly its expansion of Medicaid. I will point out at this juncture that even in states that are not expanding Medicaid, the new enrollment procedures are such that currently eligible people, and a lot of them are not currently enrolled, will find it easier to become enrolled, and health centers can be very involved in helping them become enrolled, even for traditional Medicaid populations. The huge emphasis, of course, is in the expansion states where Medicaid will be available for the first time for much of our clientele. We conduct workshops on outreach for engaging hard-to-engage people, and now moving them on into enrollment in Medicaid or in the exchange for those few who are eligible. We have webinars on the topic at nhchc.org and are developing materials like standard flyers people can use that are written at the right level of literacy around enrollment. It's very important as we grow as a movement and are more and more involved in networks with other providers that we influence their ability to effectively treat our clientele. And this is really just a call to do some things that I think we've not done so well on in the past in terms of influencing people outside of the direct health center family, because as our clients become insured, they're going to be seen by lots of other people. Ideally, we'll be in networks with those people and able to educate them about homelessness and the other social determinants of health that so affect our clientele. Major social determinant of health for us is housing. Note that electronic health records are supposed to be able to track housing status and provide that for the UDS. It's very important that health centers be asking about people's housing status. It does affect treatment plans, and it affects our advocacy in the broad term. On the housing front, health centers are required to assist with benefits. Housing is a public benefit in a number of places. I'll skip ahead to note that we are heavily invested in healthcare for the homeless, in permanent supportive housing, and the housing first approach to that, which says that you put people in housing before you try to get them ready for housing, because housing itself makes them ready for health care. It's evidence-based best practice. HRSA has recently clarified the rule on health care for the homeless grantees being able to continue seeing their patients once they are in permanent housing. Previously, we were able to serve them for only 12 months once they're in permanent housing. Now the recognition is that for permanent supportive housing, where supportive services are being provided, often by health centers, in order to keep people in housing, we can continue to serve those people indefinitely. I'll mention also on the housing front that medical respite care facilities for people who are homeless, no longer sick enough or not yet sick enough to be in the hospital, but far too sick to be on the streets. Medical respite care facilities that serve them are a central modality in healthcare for the homeless that's emerging. The barriers are pretty obvious. The exposures on the streets, we've talked about a lot of that already. Trauma I'll highlight as probably, other than extreme poverty, the greatest common denominator for homeless people. What we need to be watching for right now in terms of system developments is unaffordable copays, Medicaid, and affordable care, accountable care organizations maybe setting up copays that simply become an unsurmountable barrier for people who don't have a dollar in their pocket. A $5 copay, a $25 copay will mean just that managed care organizations get capitated rate and they don't have to provide care, because those barriers will keep people out of care. Uninsurance and fee collection are a major issue for health center programs. We encourage zero copays. Some health centers will not go there, and some do, I think, probably waste resources on trying to collect fees from people who simply don't have it. Adjusting scales appropriately overcomes that problem. There are problems for capacity. The health center program is growing, not nearly as fast enough to keep up with the need, but particularly in the area of behavioral health. The capacity of health centers is not where it needs to be. There are cultural barriers. It's a two-way street. Our clientele is not accustomed to appropriate use of the healthcare system and the healthcare system. Our own people are not always as sensitive as we might be to the needs of our clientele. Governance is an issue. Consumer governance in healthcare for the homeless is a great problem. We work very closely with the National Consumer Advisory Board to try to work with health centers and health center clients in cities across the country to make sure consumer governance is meaningful. And finally, sequestration is affecting our consumers, even if it's not yet affecting our funding at health centers. The resources available to them to deal with their nutrition, their housing, all the things they need that are down there at the bottom of the needs hierarchy are being whittled away. It's going to have an effect on demand on us and on the seriousness of the conditions to which we respond. The National Healthcare for the Homeless Council has a broad and aggressive agenda of addressing these problems. It's all brought together on our website, and I look forward to talking to you more about our resources in the Q&A period. Thank you.
Thank you very much, John. And so I am going to try and go through as fast as I can the public housing presentation so that we can get to your questions. Great. So now we're going to do an introduction to healthcare for residents in public housing. First, I want to share a little bit about the demographics. Residents in public housing, about 50% of the white race in public housing, and about 76% of non-Hispanic individuals live in public housing. Public housing is usually found in urban areas, and they are situated mainly on the east coast of the U.S., but they are dispersed throughout larger states such as California and Texas. Over 50% of residents who live in public housing have less than a high school diploma, and about 2.2 million people currently live in public housing, and these are usually sites that are funded directly from HUD, allowing individuals to receive or pay rent at a lower cost than the average person, an individual, and that's what makes their homes affordable. The average annual income for residents in public housing is $13,700 for a family. And most people live in extremely low economic conditions, and these individuals tend to have incomes 30% below the median income. In terms of health access, for most residents in public housing, health care is very limited. And we know that about 33% of the residents who are currently seen by public housing primary care health centers, they see about 33% of the uninsured residents. And the majority of the residents tend to be single-family homes. Females tend to be the leaders, heads of these households, and ironically, about 1/3% are actually headed by seniors themselves. As in public housing, we see multi-generation family members, and usually it's a grandmother, a mother, and children or grandchildren. Now, due to public housing being a low-income housing that's found in urban areas, healthcare facilities are limited. And most residents, in order to receive any kind of healthcare services, they must travel a distance, even to receive their social services and healthy foods and access. Most of these areas with public housing happen to be in food deserts, so there are not a lot of nutritious foods available for them. The average household in public housing has about 2.2 persons, and those tend to be 2.2 individuals that are on the lease. As we know, these are sometimes multi-generational housing sites, and they may have extended family members who visit from time to time. And about 62%, as we said, of public housing households are headed up by females and 38% by males. Of all the number of individuals living in public housing, 41% of the residents happen to be children. So that's a significant number, which is a large percentage of them are uninsured, and most of these families actually have to live off of welfare. And so the children are part of the SNAP program. The mothers also apply for WIC, So that's how they receive most of the subsidies in terms of taking care of their basic food needs. So this impacts about 35% of residents who live in public housing. And 55% of the residents have some form of Social Security support or pensions, especially if they're the seniors or elderly in those populations. When we look at the poverty levels, about 83.2% of residents in public housing live below 100% and below of the poverty level. And so we can see that, especially for a family of 4, where the median income is $13,000, that can be very, very, very difficult for these families. So when we look at the statistics, about 15,000 public housing primary care patients, these are the health centers serving these patients, we've seen that about 15,000 of them have received an HIV test in 2011, and 775 patients have actually been tested for HIV. That's about 5% of the population, and this data, of course, is available through UDS. And so we do know that HIV/AIDS is a very significant problem, and unfortunately, testing is not done at all health centers at the current time. And so this is just based on those individuals who have been tested. In the public housing primary care patients, they tend to have a lot of depression, attention deficits, and disruptive behavior disorders. And they are seen about 6 times a year by health centers. However, we do see also a lot of substance abuse disorders related to alcohol, tobacco, and these individuals, if followed up, the health centers tend to see more than 10 visits per patient over a year. So we see this is a very significant area for the public housing health centers. Most of the 2,000 public housing group residents have actually received a pap smear in 2011. In this population, there must be a lot of screening for STDs and so forth. So this is one of the great things that we've been able to see a lot more health centers be able to afford to do through support of HRSA funding. About 7,500 patients are treated for asthma in the public housing sites. A lot of times we have a lot of people who smoke in housing. They have asthma, the children develop asthma. Most of these asthmatics we're seeing are children, but we are starting to see a significant number in the seniors as well that live in these housing communities. The smoke gets on their walls, it's in their vents, it's everywhere, it comes under their doors. In the summertime, they open their windows. Sometimes they hang their clothes outside, and the smoke in the area gets there. So for several reasons, unfortunately, many of these children, even though we know the treatment for asthma is to avoid the trigger, it's not always possible in this setting. Patients diagnosed with overweight or obesity also accumulate about 6,000 patients a year. So when we look at the top 3 health problems that we see in public housing, according to UDS data, these are the top 3. Hypertension or high blood pressure, diabetes, and oral health. These are some of the primary reasons why residents in public housing will actually seek care. But there are a number of other conditions that you should be aware of. We mentioned a few of them already: asthma, HIV, obesity, mental health. Especially with depression and substance abuse. So we will do a quick review into hypertension, and this is really commonly seen in most minority and low-income populations. In 2011, according to UDS, about 19,000 patients were seen who are residents in public housing with this diagnosed hypertension. They have seen their doctors 2 to 3 times a year, and most of these grantees that we've seen at health centers, predominantly in these states and regions 2, 3, and 5, we have seen a significant number of hypertensive patients. So if we look at 2011 alone, we've seen there's an increase in the number of hypertensive patients that they have seen. Some of it related to the stress, to the economic situation, some of it related just to the poor eating food habits that most individuals have. And then we look at diabetes. In residents in public housing, about 13,000 diabetics are seen on average a year. We've seen a significant increase between 2010 and 2011. So this is truly one of those conditions that every the health center willing to look at residents in public housing, you absolutely have to screen your patients for. They see their providers about 3.4 times a year, and many of the many of the health centers that we see right now rank in the 4th quartile for diabetes, chronic disease management of patients, more than any other quartile. And then there are programs such as Move to Opportunity, which have been identified and associated with, has actually shown an association between low-income housing and health. And diabetes tends to be the common health indicator. When we look at oral health in a sample of public housing residents, almost 25% of adults reported having 6 or more permanent teeth missing. People with lower income education were most likely to suffer from tooth decay, and health habits such as excessive alcohol consumption, tobacco use, and poor nutrition tend to be more prevalent in public housing settings. Residents also have very limited access to oral health services, and we saw that in UTS that for the health center, the public housing health center programs, there was actually a decline in the number of oral health visits. And so we do know that this is we attribute those numbers more to the lack of oral health care that many of the health centers were able to provide. When we look at the barriers to care and healthy living, again, just like in the other populations, education. Most of the residents in public housing tend to have at least a third of 5th grade level education, at which you can really reach them in terms of medical knowledge. So when you have to deal with the residents, it's very important to make sure that your materials can at least speak to residents at that level. And again, economic hardship and unemployment, extremely high rate among this population. They have a number of comorbid conditions that add to their problems, their overall health. Limited social support, again, the very low income population, many of them are unemployed, and then there's medical mistrust. This is actually one of the most significant barriers. We've heard a lot in public housing that many of them just don't trust the medical community because when they see them come in, they might think it's the research, or they may have heard a story from a grandparent who has said that the doctors gave me medications and that gave my grandmother cancer. And this is the story that passes on through generations. So there's a lot. When public housing health centers reach out to the population, they have to really foster their trust. That relationship is key in meeting the needs of those residents. And when we look at some of those challenges for the health center programs, the financial obstacles in terms of trying to provide more care, more services, especially like oral health, mental health. Then there's the issues of what they have to meet, the enabling services, transportation, making sure there are translational services and to support their care. And cultural competency, this is very, very important. Many of the staff for the public housing centers, they must be trained to be culturally sensitive, understanding not just the language barriers, because there are multiple languages in public housing, but also understanding culturally where they are and what does it mean to them. If you talk to them about diabetes, you may have to talk about too much sugar in the blood and try to avoid some of those clinical terms. So it's a lot of training and the approach in terms of dealing with residents, and if they don't understand, they're not going to seek the care that they need. Again, and this is a high uninsured population, but thanks to HRSA, the recent grant announcements, a lot of health centers will be able to do a lot more in terms of outreach and enrollment and get their individuals qualified for Medicaid, which is most of the residents of public housing. That's the status in which the health centers will see them. Utilization of services, again, sometimes it's an issue of transportation. There are a lot of single mothers. They may not have daycare. They have to work. They can't afford to leave work and go in for care. So those are all of the reasons why sometimes, even though there are some services there, they may be underutilized, as well as there may be a lack of services that they can provide. But a lot of them try. In public housing, there's a great need for special needs care. And again, health literacy, if they could overcome that barrier and that mistrust, then there's a lot that they could do. So I'm going to just wrap up now. The National Center for Health and Public Housing provide a number of resources to help health centers really reach out to residents in public housing. We do a number of webinars, just like the one today, monographs, and that will share a lot of resources and tools available. We do a lot of fact sheets to help you, especially health centers as they're identifying opportunities to serve public residents in public housing through new access points and so forth. We provide a lot of data fact sheets on the public housing population. And then we have the newsletters, which we encourage all of our health centers to really follow up. That's where we can share best practices and so forth. And then we have the annual symposiums where we bring concentrated workshops together. So now we're going to actually open up for any questions, and we're going to ask you if we can please submit any of your questions in the text box, and John and Alexis and I will be happy to answer them for you. So, John, one of the questions is, how is the count for the number of homeless people calculated?
Each year, HUD requires its grantees in the continuum of cares in each local community to do a one-night count. And that count is widely recognized as an undercount because it targets mostly central urban cores, counts people sleeping on the streets or who appear to be sleeping in their cars. It's the biggest part of that number is always a shelter count. They do find people in emergency rooms and in hospitals, sometimes in significant numbers, but the 600,000 plus is a number they come up with traditionally. Just about every year, it's close to the same. It's the best count that there is. Other estimates take us much higher in terms of the impact of homelessness. The number you generally see, SAMHSA just put out, or ACY just put out an RFP that said that there are 1.6 million unaccompanied homeless youth in the country each year. The 600,000 number is a one-day point-in-time count, and over time it needs to be multiplied by a factor of nobody knows how much.
Mm-hmm. Wonderful, thank you. I have another question for you here, John. Can you estimate how great the homeless population is currently?
How what the homeless population is?
I'm sorry, let me repeat that question. Can you estimate how great how the insured homeless population is, roughly?
Within the healthcare for the homeless population, it's about 65%, the 60 to 70% range. I'm sorry, I'm forgetting this exact number, uninsured. The Affordable Care Act's Medicaid expansion will, in those states that adopt it, allow people to become insured strictly on the basis of their income, and almost all homeless people will qualify in those states for Medicaid for the first time.
Okay, great. I have a question here from Renee Call. She wanted to actually know where she can find a HRSA definition for public housing that can be used to by health centers for data collection. They have found some of the definitions for migrant and homeless, but not public housing. We would, at the National Center for Health and Public Housing on our website, nchph.org, we have a lot of data available, and through many of our fact sheets on this. But in terms of defining residents in public housing, some of them actually have vouchers. So it's not every individual who has a Section 8 voucher qualifies as a resident in public housing. According to HRSA's definition, the last one that was shared with us, HRSA recognizes a resident in public housing by anyone living in a public or assistance housing that is funded directly by HUD in some part. So that is, a very simplified way of providing the definition, but feel free to contact us at the National Center for Health and Public Housing, and we'll be able to clarify that with you. And again, please use our website as a resource. The next question I have, what are the best outreach strategies to reach migrant workers who only speak indigenous languages or dialects?
That is a very good question. It's difficult. I think the best way is to have people from that community. So either have people in the health center who are indigenous themselves, who speak Mixteco, or Tzviki, or Purepacha, or you could partner with community-based organizations, Farmworker community-based organizations, legal services, and they can be that link between the health center and the community.
Okay, great. Alex, I have another question for you. Is there a special cultural competency training for non-physician staff at health centers that have high migrant populations?
I don't know the answer to that question. I'm not sure if the other Farmworker Health Network members have done cultural competence training. I imagine that they have. So each one of the Farmworker Health Network members has its own area of expertise where we provide training and technical assistance. So Farmworker Justice, for example, our area of expertise is policy. And so we provide training and technical assistance on policy issues affecting farmworker health, including occupational safety and health, as well as the Affordable Care Act, and connecting them to legal services and community-based organizations. I would encourage you to contact me to get the link to the resource guide for the Farmworker Health Network. That will talk more about what each Farmworker Health Network member can provide to the health centers, or to go to our website.
Okay, wonderful. And I do know from experience, because in the past year, we actually had some cultural competency trainings done by the National Center for Farmworker Health and also health outreach partners. I think they do a number of them as well. So, but like Alexa said, there is a network of various, all of the migrant population, corporate agreements actually, and they all have tremendous resources. So we will have you or refer you to their websites as well. I do not see any more questions in the queue. Devin, I'm just going to ask you, do you have any more questions in the queue for us at this time?
There is one other one.
Okay.
The question is, how can you reach children in public housing? Are there partnerships with other school-based care and other groups?
Absolutely. So right now, one of the things that many of the health centers, the public housing health centers have done is actually apply for school-based health centers. So we as school-based centers see a lot of residents in public housing. So we are seeing that there is a trend right now where the public housing authorities are connecting with the health centers that do have the school-based programs to provide more outreach and care to children themselves. So if you are or if you have health centers who are school-based health centers, and they have a need to connect with the public housing residents more, then we can definitely try to help facilitate that relationship through the housing authorities. But that would be the best thing that you can do, is to connect first with the housing authority. A number of our resources also talk about how you form those partnerships and provide the memorandum of understanding. And also what we, as with all the special populations, it's really important that the boards of each of these special populations have 51% of the consumers. And some of them, actually, what we've seen in the school base, some of them happen to be school teachers who are on this board. So really also consider utilizing the board, their reach with residents of public housing, their reach with schools, and their reach with the housing authorities. And that would definitely be one of the ways that you can do it. Okay. Is that the final question, Devin?
Yes, it is.
Okay, great. So first I would like to share the contact information again with all our presenters today. I do want to thank them for really advocating for all of the special populations. So Alex Gill, John Lazier, thank you so much for joining me on this webinar and doing such an awesome job and really highlighting what everyone should know about these special populations. And I would also like to thank, again, all of our NCA partners who made this call possible. I must recognize all of them, the National Center for Farmworker Health, Migrant Health Promotion, Farmworker Justice, National Association of Community Health Centers, Health Outreach Partners, National Healthcare for the Homeless Council, and the Migrant Clinicians Network. Without their partnerships and collaborations, we could not have done today's presentation. But I do want to, lastly, as my final slide, really acknowledge there are multiple other populations. This is a listing of many of them. So we do want to recognize Capital Link, National Assembly on School-Based Healthcare, Community Health Partners for Sustainability, the other Public Housing Corporate Agreement, National Center for Health and the Aging, the Association of Asian Pacific Community Health Organizations, the Fenway Institute, that focuses on LGBT, and the National Network for Oral Health Access. So these are some of HRSA's national corporate agreements that stand ready to help you and work with all of you as primary care associations to really help in your outreach to special populations. With that, we would like to thank everyone for joining us on today's webinar. This webinar will be archived, and the PowerPoint slides will be available right after the conclusion of this webinar. We apologize that we went over, but we hope that the information that we shared with you today will be able to help you better outreach this special population. Please feel free again to contact any of our speakers today, and we'll be happy to connect you with our partners to make sure that all special populations are served. Thank you, everyone, for joining today's call.